Good afternoon, everyone. I, Squad Leader Ananya from Armed Forces Medical College, Pune, will be presenting 2 cases of congenital hereditary endothelial dystrophy, their management and outcome. CHED is a disease of corneal endothelium that is characterized by bilateral symmetric stromal haze, which is apparent at or soon after birth. Diffuse opacification is secondary to the abnormal endothelial cell development. It may be inherited at autosomal dominant or recessive. It is a diagnosis of exclusion. Therefore, other causes of congenital opacities must be ruled out first. Herein, we have described cases of 2 brothers who are product of the 4th degree consanguineous marriage, case 1, 9 years of age, and case 2, 14 years of age. Both of them presented to our OPD with history of whitish discoloration of the cornea since birth and associated with blurring of vision. There was no history of pain, redness, watering, photophobia, foreign body sensation, or worsening of the symptoms in the morning hours. There was no history of large eyeballs or systemic abnormalities. Both the children were born at full term by elective cesarean section and were immunized as per the universal immunization program. Nothing significant was observed in the developmental or family history. Examination of the first case showed BCVA in both right and left eye was 3/60, PR was accurate. Slit lamp examination shows diffuse haze in the cornea in both the eyes. Rest of the anterior segment was within normal limit. Fundus could not be visualized, therefore USGB scan was done, which showed retina was on. IOP in both right and left eye was 12 mm of mercury. Examination of the second case showed BCVA in both right and left eye as 1/60, PR accurate. Cornea showed diffuse haze in both eyes. Rest of the anterior segment was unremarkable. Fundus in this case also could not be visualized. USGB scan showed retina was on. IOP in both right and left eye was 16 mm of mercury. Anterior segment OCT in both the cases showed increase in the central corneal thickness. History, detailed clinical evaluation, and ASOCT confirmed our diagnosis as congenital hereditary endothelial dystrophy in both the cases. Considering the localized nature of the disease and the age of the patient, our team of surgeons decided to perform non-Descemet stripping endothelial keratoplasty in right eye of both the cases. Few glimpses from the operation theater. 350 micron partial thickness incision was made. Host cornea trephined, and it was injected with the help of Bucin endoglide. Postoperative day 1 showed lenticule was well adhered to the host with air bubble in the anterior chamber in both the cases. However, 10th postoperative day showed graft was dislocated partially and the cornea appeared opaque in both the cases. ASOCT showed a gap in the host and the lenticule, which confirmed the diagnosis. Therefore, rebubbling was done on postoperative day 13. 3 days post rebubbling, the cornea showed significant clearing with intact air bubble in the anterior chamber in both the cases. Central corneal thickness showed significant decrease. 10 days post rebubbling showed further decrease in the corneal edema with intact air bubble in the anterior chamber. Central corneal thickness in the first case reduced from 740 to 730 micron, and in the second case from 900 to 870 micron. 6 months post-operatively, we could achieve BCVA of 6/60 in the right eye of both the cases, and PR was accurate. Central corneal thickness was further reduced to 619 and 720 micron respectively. CHED was first reported by Lawrence. Until many decades, conventional PK was done for all the cases of CHED until when DSEC was described as an alternative. However, performing DSEC in a child with CHED poses many challenges, like limited anterior chamber clearance, poor visualization of the cornea due to clouding. A few modifications in the surgical procedure may help, like using trypan blue dye for staining the Descemet's membrane, chandelier endo illuminator, and performing EK without Descemet stripping. The different advantages of non-Descemet stripping are no suture-related complications, tectonic stability, early and better stabilization, and reduced risk of rejection. Various studies have also shown EK as a suitable alternative to conventional PK, as it reduces the risk of suture-related infection, astigmatism, longer use of corticosteroids. Therefore, meticulous workup for a child presenting with corneal clouding should be done. EK is a feasible option in pediatric patients. DSEK allowed rapid restoration of the corneal clarity, and one of the commonest complication of DSEK is graft dislocation. Thank you so much.
So do you not strip in every case? Is there any criteria for you to strip the decimates?
Sir, in pediatric age group, usually we avoid stripping of Descemet's membrane because the Descemet's membrane is very tightly adherent in such cases, and inadvertently we cause injury to the lens while stripping the Descemet's membrane and to the posterior stromal fibers as well.
But if the child is older, if you have scarring seen on OCT, you need to strip the decimates because otherwise the results are not that good.
Right, sir.
Thank you. Thank you.